Good evening, everyone. I'm Dr. Ali Khalid, consultant endocrinologist and thyroidologist working at Imperial London Diabetes Center, Abu Dhabi. I'll be chairing this session reserved for thyroid nodule. It will be part one. There will be another session on May 23rd that will address different aspects of thyroid nodule management. I'll be co-chairing the session, and my co-chair is Dr. Alauddin Bashir, who is a consultant endocrinologist and thyroidologist at Dubai Hospital. Dr. Alauddin is very well known in the field of thyroidology, has been very active. He's part of ECNO and well respected in his field. We'll be chairing both of us. I'll be addressing the first two speakers, and then he'll take over for the other remaining speakers. I would like first to thank ADES for organizing those sessions. And it's worth mentioning that this webinar will be streamed on ADES YouTube channel if you would like really to go back and attend it as live session. It also, if you would like really to retrieve it from the ADES Institute website, you can do that. You have to create an account, and you can, the webinar will be recorded and registered in that website. At the end of the session, there will be a question and answer session. Would like you really to be interactive and ask the question that you would like us to undertake, but please indicate not only the question, but the speaker that you would like to reply to this question for you. And finally, if you have any technical issue, you can reach us through live chat support on WhatsApp during the event. And you have the phone number is 971-56994-4287. The webinar is being given 2 CME accreditation. You will be asked at the end of the session or within the first 2-3 weeks to evaluate the program, and based on that evaluation, you will be receiving your CME accreditation. Having said this, I think it's time to start with the first speaker. This first speaker is really well known to all of us. I mean, and especially in the field of ultrasound of the thyroid. Dr. Suzanne Mandel is a professor of medicine and radiology and chief of the Division of Endocrinology, Diabetes and Metabolism at the Perelman School of Medicine, University of Pennsylvania. Her clinical practice focuses on thyroid neoplasia, and her research interests include sonography and the evaluation of patients with thyroid nodule and cancer. I have to say that a lot of the contribution in the ATA initial guidelines on ultrasound was geared partly by Dr. Suzanne, so it's a great pleasure to have her giving us the first talk on risk stratification of thyroid nodule, ATA, and thyroids.
Good evening, and thank you for joining. Today I will talk about risk stratification systems, the American Thyroid Association, and the American College of Radiology. And let me share my screen. I have no financial disclosures. However, I was a member of the 2015 American Thyroid Association Guidelines for the Management of Patients with Thyroid Nodules and Thyroid Cancer, where the ATA sonographic system was developed. And I'm co-chairing the 2022 American Thyroid Association Guidelines with our head and neck endocrine surgeon, Lisa Orloff. The way I've organized this talk is to talk about the background and epidemiology of thyroid nodules, thyroid cancer, and then to talk about the ACR TIRADS and ATA sonographic pattern systems, the key components of these symptoms, and then to evaluate them in different clinical scenarios as we implement these systems, as well as the limitations of both of the systems. So the background for thyroid nodules. Well, we know thyroid nodules are very common and the prevalence increases with age. We know that very few are malignant, but there has been a threefold increase in thyroid cancer incidence over the last 30 years. And currently, ultrasound is the primary modality for evaluating thyroid nodules for risk stratification. And it's the cumulative ultrasound features that are predictive of the risk of cancer. But most importantly, if you don't have the suspicious features, that's predictive of benignity. And then FNA is our standard technique to obtain cytology to assess for malignancy. So if we look at the correlation of thyroid ultrasound and the increase in the diagnosis of thyroid cancer, I turn to some data from the United States where you can see that between the decade of about 2002 to 2013, ultrasound as the initial imaging test increased about 20% annually. And this is in a Medicare population. So as the initial test ordered, this increased. And this was therefore correlated highly with the increased incidence in thyroid cancer. And we all know that many nodules are now found quite incidentally in other imaging studies or even on ultrasound. And the call was that as we are doing more and more ultrasounds and diagnosing more and more small cancers, we need to adopt risk stratification tools so that we are trying to diagnose clinically relevant thyroid cancers. So if you actually look at the risk of thyroid cancer, and this is in the United States in females and males, you can see there was an increase in the incidence of thyroid cancer, really starting at around 2000. And this really correlates with that use of ultrasound. But if you look more closely over the last several years, there has been a decrease in the incidence of thyroid cancer, and the inflection point is around 2015. And if you actually look at the number of new cases predicted in the United States, you can say this is going down. In fact, this year in 2022, it's the lowest in the last 7 years. And this has actually been correlated in this recent paper in Thyroid with the use of ultrasound risk stratification systems to evaluate cancer risk in nodules and then associated with higher FNA size thresholds. So evidence-based guidelines can help us to potentially diagnose the more clinically relevant thyroid cancers and not the smaller cancers, which may be incidental and which may have led to the overdiagnosis of thyroid cancer. So what are these ultrasound risk stratification systems? Well, they're tiered categories that are correlated with malignancy risk. And then once you're in a category based upon the malignancy risk, there's a different size threshold recommended for FNA. And so it lets us know when to perform FNA, but most importantly, if an ultrasound imaging picture of a nodule is associated with such a low risk of cancer, it tells us when we don't need to perform an FNA. And there are many strong opinions about these systems and when to use them. So the two I'm going to focus on are the American College of Radiology Thyroid system, which is a sum of points for individual sonographic features, and the American Thyroid Association, which is a pattern-based atlas. And because this was written for clinicians, by clinicians, this one also has some descriptors that this could be modified by patient-specific factors. But what I want to draw your attention to below are the two dates in reds. This is pretty new, 2016 and 2017. So using ultrasound for a long time, but finally getting these risk stratification systems over the last 6 years. So what are these major characteristics that can be associated with malignancy? Well, composition. What I've shown in blue is the feature of the characteristic that's associated with benign nodules, and in red, that's associated with malignant nodules. So solid composition nodules are more likely to be malignant. Echogenicity is the darkness of the nodule compared to the background thyroid. So hypoechoic or darker nodules are more likely to be malignant than hyper or isoechoic nodules with the same echogenic grayscale features. A nodule that is taller than wide is more worrisome than a nodule that's wider than tall. Margins that are irregular, so we can see them and they're infiltrated or spiculated, are much more worrisome than nodules that are smooth or indistinct. And when we come to echogenic foci, which are bright spots, it's punctate echogenic foci, in the past called microcalcifications, but the correct term is PEFs, or disrupted coarse calcifications that are more worrisome. So if you look at ACR TIRADS, Here are our 5 categories: composition, echogenicity, shape, margins, and echogenic foci. And there's a point system where within each of these categories, the features that are more associated with malignancy are attributed with more points so that you get a higher sum. And it's the sum that determines the risk level or the TR level. And this leads to recommendations for FNA or surveillance if no FNA. So this is what ACR Thyroids looks like. Here are 5 categories. Here are the features within the categories. And the more points you have, that feature in that category is more likely to be associated with malignancy. And then here are the actual Thyroids categories that are correlated with the number of points. So again, in ACR Thyroids, the cutoffs for FNA are modified by sonographically suspicious lymph nodes, but patient clinical factors such as a history of external beam radiation as a child does not modify FNA size cutoffs. So a couple of points. Very importantly, for spongiform, they specifically state, do not add further points for other categories. So a spongiform nodule, you're done. It's not isoechoic and mixed, you are done. For mixed cystic solid nodules, you can add points for the predominantly solid component. Echogenicity. If you cannot determine echogenicity, Thyroids allows for 1 point. And margins, I want to point out that if the margin cannot be determined, you get 0 points. An ill-defined margin is not the same thing as an irregular margin or a lobulated margin. Now, this is the ATA sonographic pattern system. So going from benign, very low suspicion, intermediate, and high. But what's given here are classic images that would be associated with nodules in those tiers. Now, these categories and FNA recommendations are also modified by the presence of sonographically suspicious lymph nodes, but also potentially by patient risk factors. So let's go through these because they are very, very similar in how they categorize nodules. So this is a cyst called benign, or this would be Thyroids 1, cystic 0 points. Both guidelines recommend no FNA. But let's come to the more common imaging of nodules. So these are very low suspicion nodules. This is the classic spongiform nodule, remember 0 points. And then these are the mixed cystic solid nodules where you would get 1 point for mixed cystic solid and 1 point for isoechoic. All of these are very low suspicion ATA. And remember what Thyroids does say is that you can have these small echogenic foci that are seen posterior to these walls of these microcysts, and these are not suspicious and should not be considered punctate echogenic foci and should not add to the point total. Now, both guidelines recommend observation as one strategy, but the ATA also had allowed for FNA with nodules when they were over 2 centimeters. But in practice, most of us are observing these nodules. Let's turn to the next category. This is the ATA low suspicion, or Thyroids, predominantly 3, but I'm going to show you how one of these nodules can still be considered a Thyroids 2. So these are the isoechoic or hyperechoic solid nodules. So you can see both of these nodules are solid. They both have smooth, regular margins. So 1 point for iso or hyperechoic, 2 points for solid. These are the images for ATA low suspicion. These are Thyroids 3 nodules. However, here again, you're going to see a pattern where in general, Thyroids will FNA at a slightly higher threshold than ATA. So some differences. This is where they differ. In these mixed cystic solid nodules, the ATA will consider them low suspicion because the solid part is uniformly isoechoic, whereas ACR Thyroids will consider them mixed cystic solid and isoechoic Thyroids 2, for which no FNA is recommended. And so observation would be for these nodules, whereas ATA would still biopsy them. And I just show you a pitfall because this would be a nodule that has been classified as a Thyroids 2 nodule, but would be ATA low suspicion. And this was a papillary cancer follicular variant. So let's move up to the next category. This is ATA intermediate suspicion, or Thyroids 4. These are hypoechoic 2 points, solid 2 points, nodules with regular borders. These are the images from the ATA sonographic pattern system. Thyroids 4, solid 2, hypoechoic 2. Both again recommend FNA. As always, the ACR is slightly higher cutoff than the ATA. And then lastly, this is our highest suspicion nodule. So all of these are solid, so they'll all get 2 points. This is hypoechoic with irregular margins. So this one is actually a Thyroids 4, not quite 5. But if you consider this markedly hypoechoic, then it would be awarded 3 points rather than 2 and would be a Thyroid 5 nodule. This is hypoechoic with irregular margins, punctate echogenic foci. So this gets a total of 9 points, Thyroid 5. Hypoechoic, irregular margins taller than wide, Thyroid 5. Hypoechoic, extrathyroidal extension, Thyroid 5. Hypoechoic with an interrupted rim calcification and soft tissue extrusion, again, Thyroid 5. And this is a nodule with a suspicious lymph node. So all HEA high suspicion and mostly all Thyroid 5 nodules and FNAs at the lowest size cutoff. And remember, all ultrasounds need to evaluate the cervical lymph nodes. So what about subcentrometer nodules? Well, both HEA and ACR recommend against routine biopsy of these subcentrometer nodules, provided there's no extrathyroidal extension or abnormal lymph nodes, and there can be shared decision-making. Now, as I sort of mentioned, there are other potential modifiers of the FNA size cutoffs. The HEA does modify by certain clinical characteristics. So ACR does not modify by any patient characteristics shown here, but the HEA does, not by age, but medical comorbidities. You might defer a nodule. If there are risk factors for thyroid cancer, such as external beam radiation as a child, you might biopsy at a smaller size threshold. And there is accounting for PET scans that you might biopsy at a smaller size threshold. Now, unfortunately, in HEA, it turns out that there are non-classifiable nodules because we don't use that point system. And you can see here are studies spanning 3 different continents that it ranges from about 5 to 15%. And the malignancy rate is probably around 10 to 15%. So the general conclusion from this is that the non-classifiable HEA nodule should be considered HEA intermediate suspicion. And let me show you some images of those. This is a solid isoechoic nodule, but it has an irregular margin. Let me show you the irregular margin on the clip. And you can see there's a little bit of an irregular margin over here. And so this would be non-classifiable by HEA, but this is classifiable by ACR, and this should be considered intermediate suspicion. Now, here's another nodule, non-classifiable by HEA, because it's mixed cystic solid, but it has punctate echogenic foci in the isoechoic spot, part of the nodule. This is considered a Thyroid 4 nodule, but non-classifiable by HEA. And then lastly, you can have solid nodules with mixed echogenicity. You can see it's hypo and isoechoic. You can see it nicely over here. So ACR Thyroids can allow 1 point for the echogenicity cannot be determined, but all of these nodules, these HEA non-classifiable nodules, can perform or can be considered like the HEA intermediate suspicion nodules. And I will tell you that in the new classification system we'll published in 2022, we will be able to classify these. So how do you evaluate? When we're looking at this, we'll evaluate inter-observer variability. We'll evaluate prediction of malignancy risk by the tiered categories. How good are they? And how do they perform for cancer diagnoses? And how do we adapt these risk stratification systems once we've biopsied a nodule? Can we use these risk stratification systems to help guide us in the management of nodules with benign cytology, with indeterminate cytology? And can we use these risk stratification systems to develop a strategy for the follow-up of nodules that are not biopsied because they don't meet that FNA size cutoff? So I'm going to use these 5 criteria to comparatively evaluate the performance of ACR Thyroids and the HEA. So inter-observer variability. So we know a lot about this. The experience of the operator is critical. There have been a number of studies that have evaluated academic radiologists versus community radiologists and have shown that these systems perform much better with the experienced operator. Education and training is in essence the same thing. There are a number of studies that have evaluated resident or fellow performance compared to attending performance, and attending performance is better. What about scanning techniques? We all know, those of us who do ultrasound, that how you compress, how you set the gain, what package you use for the post-image acquisition processing can determine how the image looks, and that can affect image interpretation. And then what about agreement? So if I look at an image and classify it, let's say, as an HEA low suspicion Thyroid 3, and my colleague at the same institution does this, how likely are we to agree? So for single institution studies, these are the kappa values for ACR Thyroids and the HEA, and you can see they mostly fall in the moderate to substantial agreement, so that individuals within the same institution who practice together tend to agree about how nodules are classified. However, there's a wonderful study that was done at 3 hospitals in Rome, so different centers, so those individuals don't practice together, and you can see the agreement falls in for both systems significantly. So in other words, education is important and that everybody is on the same page. There's a real knowledge gap, especially in the learning of how to use these classification systems. Second category is how well do these predict malignancy? So what I've shown here is the ATA, the categories, and the expected range of malignancy. And then from this large study in Poland, what the actual calculated range of malignancy was for all of the nodules they evaluated. And you can see that it's pretty good, except for the high suspicion where the calculated rate of malignancy was lower. And in our guidelines, we had actually said that when we estimated 70 to 90%, we derived this from high volume centers, and it was very possible that the rate of malignancy might be lower when this was applied because of the inter-observer variability in sonography and what's seen in different centers. And for ACR Thyroids, again, here is the expected rate of malignancy and the calculated rate of malignancy in this Polish study. And you can see that they're very concordant. So these tiered risk categories do predict malignancy. Now, what about the performance for cancer diagnosis? The next thing I said we were going to evaluate. So there are some caveats here. All of the studies that correlate the classification of thyroid nodules subsequent FNA with cancer risk exclude nodules that are non-operated. And this often includes nodules with Bethesda 1 non-diagnostic and non-operated Bethesda 3 and 4 cytology results. So when we're looking at the performance of these risk stratification systems for prediction of cancer or benignity, often in many of these data sets, there's exclusion of indeterminate cytology nodules that are non-operated and non-diagnostic cytology nodules. And so therefore, the accuracy of these risk stratification systems is really for papillary cancer, not for medullary generally, and not for follicular, which generally falls in the categories 3 and 4s. And we don't know the truth about those if the nodules don't all undergo operation. And so this is a very nice meta-analysis that's really shown that when you look at all these risk stratification systems, it's for papillary cancer, because all of these studies, when you put them together, the population of cancers is 95% papillary cancers, which is actually higher than what all of us see in practice and very low for the follicular cancers. So again, the risk stratification, when we're looking at its performance, it's for detection of cancer, generally papillary cancer, and unnecessary biopsies for benign nodules. And when we actually talk about performance, since I just showed you that ATA and ACR Thyroids classify nodules into the risk stratification systems very similarly. Remember, there's concordance between ATA low suspicion Thyroids 3, ATA intermediate suspicion Thyroids 4, ATA high suspicion Thyroids 5. When we're talking about implementation, it's all about the FNA size cutoffs. So if we talk about sensitivity, and this is a meta-analysis looking at ultrasound performance for detection of cancer, you can see that because ACR Thyroids in general has higher FNA size cutoffs, the sensitivity for cancer is lower, whereas for ATA with lower FNA size cutoffs, the sensitivity is higher. But because you're biopsying more nodules with lower FNA size cutoffs, the specificity isn't as good. You're biopsying more benign nodules. And because you're biopsying fewer nodules with the higher FNA size cutoffs in ACR Thyroids, the specificity is higher. But again, just to show you this, it's not about the classification, it's about the size cutoffs used. And I take this large data set of almost 1,400 nodules from Korea, where they specifically looked at sensitivity and specificity using the FNA size cutoffs recommended. And as we just showed, not surprisingly, ATA, because it uses lower size cutoffs, has higher sensitivity, but lower specificity. But what if we just change it? So we use the same classification system, but we change the cutoffs in ATA to reflect those of ACR Thyroids. So for an intermediate suspicion nodule, we biopsy at 1.5 centimeters rather than 1. For a low suspicion isoechoic nodule, Thyroids 3, we biopsy at 2.5 centimeters rather than the ATA 1.5 centimeters. And for a very low suspicion nodule, Thyroids 2, we don't biopsy. And you can see that all of a sudden the sensitivity improves, as does the sensitivity, remains very much the same, but the specificity improves. So it's not so much about the classification, it's about the FNA size cutoffs. And in my practice, I tend to use the TI-RADS size cutoffs. So what about other clinical applications? Can you use these risk stratifications to help in the follow-up of nodules with benign cytology? So the answer is for ACR TI-RADS, you cannot. It is specifically for non-biopsy nodules. But for the ATA in the guidelines, you can use the baseline sonographic pattern to develop a tiered risk approach for the follow-up of nodules with benign cytology. And this, in summary in color, is what we've written in the guidelines, that if you have a nodule with benign cytology and the ultrasound pattern was very low, you really don't need to follow that nodule. Whereas if you have a nodule with a high suspicion ultrasound pattern and for some reason got a benign cytology, that's where the false negatives are. And you should repeat the FNA within the first 12 months. And for nodules with benign cytologies that fall somewhere in the middle, there's not great evidence, but you kind of follow them, you repeat the ultrasound in 1 to 2 years, and you consider FNA if there is either significant growth or development of new suspicious features, but there's not great evidence for this. However, this type of approach has been evaluated in this recent paper and has shown that it is a pragmatic approach to the follow-up of nodules with benign cytology. Now, what about for Bethesda 3 and 4 nodules? So you've biopsied a nodule, it's indeterminate. Can the baseline ultrasound pattern tell us something about the cancer risk? And the answer is yes, and this includes cancer and IFP. So here is a study looking at over 300 nodules with Bethesda 3 or 4 cytology, where the baseline cancer risk was 31%, and looked at the baseline ultrasound pattern by ACR TI-RADS or ATA. And what's shown in red is the proportion of nodules with Bethesda 3 or 4 cytology that were cancer and the proportion that were benign. So if we look at our lowest risk stratification category, you can see that if you have a Bethesda 3 or 4 cytology and your ATA very low or TI-RADS 2, those nodules are not cancer, and you don't have to do molecular testing and you don't have to do surgery. On the other hand, if the nodule with Bethesda 3 or 4 cytology is high suspicion or TI-RADS 5, those nodules have an over 74 to 79% chance of cancer, and those nodules should probably go directly to surgery. Whereas the majority of nodules that are Bethesda 3 or Bethesda 4 actually don't fall into TI-RADS 2 or TI-RADS 5 or very low or high suspicion. They're in these ACR TI-RADS 3, 4, ATA low intermediate patterns where the risk of cancer remains somewhere between 10 and 35%. And there, if you have molecular testing, you can use it, or their patients often undergo diagnostic lobectomy. But it can help if the ultrasound is very low risk or high risk. So to summarize, for TI-RADS 2 or ATA very low suspicion nodules, you don't need to do molecular testing or surgery. If it's a high suspicion nodule, Bethesda 3, 4 cytology, those should go to surgery. Now for non-FNA nodules, so let's say you do that ultrasound and the nodule doesn't meet criteria, do these risk stratification systems give us a way to follow the nodules based upon its baseline sonographic pattern? And here for non-FNA nodules, the ACR gives us some guidance where this is what's shown in their paper, that for a TI-RADS 1 or 2 nodule, you don't follow it. For a TI-RADS 5 nodule, you do repeat the ultrasound. And then for TI-RADS 3 or 4, they have this number of years at which you repeat the ultrasound, and you can stop ultrasounds at 5 years of stable. But this is variable quality of evidence to support these recommendations. And for the ATA, there's really no size criteria or time cutoff, but it's the general idea that if the nodule is very low suspicion, you really don't have to follow it. If it's very high suspicion, you should repeat the ultrasound very soon and consider FNA if it grows. And if it's somewhere in the middle, you repeat the ultrasound in an indeterminate time. So we need to really work on a strategy for these non-FNA nodules, but this is what exists in using our current ATA and ACR TI-RADS. So with all of this, we're always going to have challenges in classifications. It's always easy to see the fish in the sea and the birds in the sky, but there's always some transition in the middle where it's hard to know if it's a sea animal or a flying bird. And so just to show you one couple of nodules with these challenges, here is the same nodule shown in the sagittal and the transverse view. In one view, this looks hypoechoic. In the other view, it looks isoechoic, excuse me. So it becomes a challenge of the classification of this nodule. And I think this shows you some of the challenges with ultrasound physics. Generally, these nodules, when you do a real-time clip of them, tend to look more isoechoic. And then here's another nodule where we could look at composition and echogenic foci. So would you call this predominantly solid isoechoic TIRADS 3 or HEA low suspicion? But then what would you do with these echogenic foci? Are these small linear foci behind cysts, or are these punctate echogenic foci, which are more worrisome? And I even show you this on the clip here, where some of them look like they're more linear behind cysts and some of them look more punctate and echogenic foci. And then here's another one just to show you. So here's a nodule. You'd say, well, it's mixed cystic solid and there's a macrocalcification, but I want you to look at the margins. On this particular image, the margins look smooth, but when I show you the clip, look at the margins right over here. You can see that the margins here in the superior aspect of this nodule are kind of irregular or infiltrative, and you wouldn't see that if you just looked at that static image. So you can see there are still many nodules that are quite challenging to classify. So in conclusion, our risk stratifications, whether ATA or ACR TIRADS, provide effective risk stratification predominantly for papillary cancer, not follicular or medullary. And it's the size cutoffs that dominate the assessment of performance, where ACR TIRADS generally has slightly higher size cutoffs than the ATA. And so therefore, the sensitivities and specificities are really based upon what the FNA size cutoff is, but the risk stratification is very similar. There's certainly a knowledge gap in training, and education could certainly improve that inter-observer classification. And there will always be challenging sonographic nodule imaging scenarios that are going to be difficult to address in any scenario and require comprehensive imaging and thoughtful consideration. Future directions, other ultrasound technologies like contrast and elastography, which is already used in Europe, but most importantly, artificial intelligence. And there was a recent paper published that specifically focused on challenging nodule imaging scenarios and reported that AI may actually be helpful there. But in general, AI to date has been shown to be better than an inexperienced operator, but performs the same as an experienced operator. And with that, I'd like to thank you for your attention, and I hope you enjoy the meeting.
Thank you very much. I would like to read, that was a great presentation by Dr. Suzanne. Now it's my great pleasure to introduce the second speaker. Second speaker is Dr. Sarah Mason. As you have noticed, as much as the ultrasound features are essential really in risk stratification, it is as much really important to know the biology of the thyroid nodule that you're addressing. And for this, Dr. Sarah Mason, who is Director of the Endocrinology Fellowship Program and Associate Professor of Medicine in the Division of Endocrinology, Diabetes, and Metabolism at the University of Colorado School of Medicine, will be addressing the issue of molecular markers with focus on non-BRAF gene mutation. So welcome, Dr. Sarah. The floor is yours.
Well, thanks so much for joining me today to discuss molecular evaluation of thyroid nodules. My name is Sarah Mason, and I'm an Associate Professor of Medicine and the Fellowship Program Director for Endocrinology at the University of Colorado in the United States. I have no disclosures to report today, and I'd like to set the stage with a case. This is a 43-year-old man with hypothyroidism and a recently detected right thyroid nodule. The patient has no risk factors for thyroid malignancy, specifically no personal history of ionizing head and neck radiation exposure or family history of thyroid cancer, and he has no symptoms related to his nodule. He's taking levothyroxine and his serum TSH is normal. His neck ultrasound is shown and demonstrates a 3-centimeter right upper pole thyroid nodule that's hypoechoic and solid with smooth, well-defined borders and no high-risk features. According to the American Thyroid Association's 2015 risk stratification system, this would be considered intermediate suspicion pattern. And according to the American College of Radiology's TIRAD system, this would be TIRADS 4. The patient has no contralateral thyroid nodules or abnormal cervical lymph nodes, and he undergoes FNA, which demonstrates Bethesda 4 cytopathology suspicious for follicular neoplasm. Patients with indeterminate thyroid nodules, such as in the case that I've just described, can be appropriate candidates where we consider the use of molecular testing. However, when using molecular testing as a rule-out test for thyroid cancer, it's important that we just apply molecular testing in the context of Bethesda 3 or Bethesda 4 cytopathology, as the pretest probability of thyroid cancer in the context of Bethesda 5 cytopathology is simply too high, such that your post-test probability of cancer remains, again, too high for you to recommend clinical management for a patient with negative molecular testing. Thus, we can't use molecular testing as a rule-out test in this context. However, a developing application for molecular testing is to yield prognostic or even therapeutic information in the context of indeterminate nodules or even thyroid malignancy, and we'll touch on this a little later in this talk. So first, I wanted to talk about what the perfect molecular test would be. Well, this test would be applied to thyroid nodules with indeterminate cytopathology, so Bethesda 3 or 4 cytopathology, and it would have a high negative predictive value that was similar to that of benign cytology, so greater than or equal to 97%. In addition, this perfect molecular test would also have a high positive probability, a high PPV, which would indicate a risk of malignancy that's similar to malignant cytology, so 97 to 99%. And using this test, we would perfectly be able to triage our patients with indeterminate cytopathology into two different buckets. Those who should be treated as if they have benign or Bethesda 2 cytopathology and undergo clinical and ultrasound follow-up, and those who should undergo a therapeutic thyroid surgery. So that's the perfect world. We're not quite there yet. So this is simply a historical timeline over the last 10 years that shows the considerable evolution in molecular testing that's occurred and includes many of the molecular tests that are currently on the market as well as their prior iterations. And we'll discuss many of these in a little more detail. So these are what I consider the big three in the United States, at least, which are the Afirma genomic sequencing classifier, the Thyrosiq genomic classifier, and the Thygenics Thyromir Test. And I'll focus most of my discussion today on the first two tests, but I do want to briefly mention the Thygenics Thyromir Test. This test combines next-generation sequencing of DNA and RNA to evaluate for gene variants and fusions in 10 genes. And it combines this with the Thyromir component of the test, which is a gene expression analysis of 10 microRNAs. And ultimately, through a complex algorithm, the final results that you'll receive for your thyroid nodule are either a positive, negative, or a so-called moderate result. So now let's focus a little bit more on the Afirma GSC. So just to kind of backtrack a little bit, as many of you are familiar with, the original Afirma test, the gene expression classifier, or GEC, was a 142 gene microarray-based test that categorized thyroid nodules based on mRNA expression. And GEC, as does GSC, classifies thyroid nodules as benign or negative, or a suspicious or positive test. And that's according to the probability of malignancy that's derived from the pattern of expression. One of the limitations of this test was that it resulted in a relatively high number of false positives with Hürthle cell lesions. So in the context in particular of hyperplastic Hürthle cell nodules that are non-neoplastic. The newer gene sequencing classifier, or GSE, combines RNA sequencing through next generation sequencing technology to evaluate gene expression with machine learned algorithms. So with this particular test, there's an upstream component that includes the ability to identify parathyroid tissue, medullary thyroid cancer, as well as some common mutations associated with papillary thyroid cancer, including BRAF V600E and RET PTC fusions. And if any of these are identified, then the core classifier is bypassed and you receive your result. There's also a follicular content index that ensures sample adequacy, and all of the remaining nodules that, again, don't have results from that upstream component will then go through this so-called ensemble model of classifiers, which incorporates two specific classifiers that improve the performance of this particular test in the context of a Hürthle cell lesions. And these are the Hürthle cell index and then the Hürthle neoplasm index. We then receive a binary result, which is a Afirma GSC suspicious or positive, or an Afirma GSC benign or negative result. So GSC was first validated through a large multi-center clinical validation study in 2018. And this study used samples from the prospective GC validation trial that was previously published. An adequate sample was available for 190 of the lesions from the GC validation cohort, because again, it used those stored samples from the prior cohort. And histopathology diagnosis had been established previously during the GEC validation study. And thus, in this particular study, at least, the prevalence of NIFT-P was unknown because NIFT-P didn't exist at the time that those histopathologic diagnoses were determined. So in comparison to GEC, you can see that the sensitivity of GSC was comparable at 91%, but with an improved specificity of 68%, and a negative predictive value of 96%, positive predictive value of 47%. And you can see here that the rate of cancer or the rate of malignancy in the GSC validation study was lower than that in the GEC validation cohort. And that's simply because the GSC validation study included only Bethesda 3 and 4 thyroid nodules and not Bethesda 5, which had been included in that original cohort. And then the benign call rate in this study was 54%, where benign call rate simply refers to the percentage of molecular tests that resulted in a benign or negative result. And generally, these are the patients that will end up being managed non-operatively, at least in most cases. So here are several studies summarized in one figure that have since evaluated the performance of the Afirma GSC test and compared that to GEC in their own patient populations. You can see that the benign call rate for GSC in red was higher in all of these studies, ranging from 61 to 76% in comparison to the benign call rate for GEC, which was less than 50% in all of these studies. I want to point out that the higher benign call rate in most of these studies was largely attributable to the lower rate of false positives with Hürthle cell nodules. So again, overcoming that limitation from the prior Afirma GEC test. I next want to mention Expression Atlas, and this is a separate test that can be ordered in conjunction with GSC in the case of positive results or ordered separately in the case of thyroid cancer. Expression Atlas uses whole transcriptome RNA sequencing to detect gene variants and fusions in the thyroid nodule that's being evaluated. The original version of Expression Atlas included 511 thyroid-related genes, while the current version of the test, which was first rolled out in March of 2020, includes a larger panel of 593 genes. The clinical validation study for Expression Atlas used the same cohort of nodules as the GC and GSC validation studies, but a more recent study that was industry initiated included a retrospective cohort of more than 50,000 consecutive thyroid nodules, including more than 16,000 nodules that were GSC suspicious and had Bethesda 3 or Bethesda 4 cytopathology. Overall, it was demonstrated that 42% of the nodules with Bethesda 3 or 4 cytopathology and a suspicious GSC result harbored one or more mutation or fusion using that original thyroid gene panel with Expression Atlas, while this increased by 2% with that expanded panel that was introduced in March of 2020. The study authors also evaluated a smaller cohort of Bethesda 5 and Bethesda 6 thyroid nodules, and they found that 46% of those Bethesda 5 and 6 nodules had a mutation or a fusion that could be identified using Expression Atlas, and that 1% were found to have more than one genetic alteration. I do want to point out one caveat of this particular test. Because this utilizes RNA as the genetic material of interest, it cannot detect variants in non-coding regions of DNA, such as the TERT promoter. And I'll show you some examples of why this might be an important area to document genetic alterations a little later on. But first, I'm going to shift gears and talk about Thyrosiq genomic classifier, also called Thyrosiq version 3. So the original Thyrosiq test was actually a 7-gene panel called Thyrosiq version 0 that was introduced in 2007. And then there's been several other iterations of the test that have been introduced over the last decade or so. In 2013, the test started utilizing next generation sequencing, similar to the Afirma test, which the current version also uses next generation sequencing. And the current version of Thyrosiq analyzes 112 different thyroid cancer-related genes to detect 4 classes of genetic alterations, which include mutations, gene fusions, copy number alterations, and abnormal gene expression. I want to mention that upstream of the panel to evaluate for genetic alterations, there's a quality assurance step that ensures there's a sufficient sample for analysis. There's a cellular composition piece that evaluates for follicular cells versus parathyroid cells versus C cells and so forth in order to determine the origin or the type of cells that are present. And again, similar, as I mentioned, to the Afirma test. And then ultimately, test result interpretation is based on a molecular database that's called Thyrosiq MD. And you'll receive a specific report for your patient that has a negative or positive result overall, and then a detailed description of the genomic findings that were identified, including kind of specific range of malignancy risk for that particular genetic profile. I do want to mention that Thyrosiq has been validated for use on FNA smears. And so if you're seeing a patient who has indeterminate cytopathology but doesn't have a fresh FNA sample that was saved during their biopsy for molecular testing, you can send a smear for analysis for Thyrosiq testing. And what I want to highlight from this particular study was that the performance of testing using Pap smears, which are alcohol fixed, is significantly better than with air dried smears like Diff-Quick smears. And so if you are going to send a smear for molecular analysis, it's preferable to use an alcohol fixed smear, such as a Pap smear, rather than an air drying smear, in order to increase your overall yield. But if you are able to collect a fresh FNA sample for a patient undergoing biopsy at the time of their initial biopsy, for example, not necessarily sending them back for a second procedure, that would be preferable over sending a already collected smear. So the Thyrosiq GC clinical validation study was a prospective multi-center double-blinded study that included 10 clinical sites, 9 of which were in the United States and 1 was international. There was central pathology sample review by a panel of 3 expert thyroid cytopathologists, just general pathologists, and the final study set included 257 samples that had informative molecular testing. I want to mention that about 8% of nodules in this study had what are considered GC scores of 1, and that means that they harbored low-risk genetic alterations that alone are thought to be at very low risk for the development of malignancy. Commercially, these test results are reported as currently negative when you receive your Thyrosiq report, and in this study, they were considered negative results when the test performance of Thyrosiq was evaluated, including sensitivity, specificity, and so forth. The sensitivity of the Thyrosiq test in this study was 94%. The specificity was 82%. The negative predictive value was 97%, and the positive predictive value was 66%. And this is in the context of a cancer NIFP prevalence of 28%. The overall benign call rate was 61%. So that means that 61% of the tested nodules were negative overall. And there were 11 NIFP nodules included in this study, and all were classified as positive, which is appropriate in my opinion, since NIFP represents a thyroid neoplasm with malignant potential, and generally, at least at the current time, is managed operatively. The basis of the Thyrosiq test is the genetic alterations that can be detected. And as many of you know, different molecular alterations are associated with different likelihoods of malignancy or NIFP, and also different tumor types. This table is from the study that I just went through, the Stewart et al. Clinical validation study. And just as an example, in this study, the different genetic profiles were subclassified. You can see that the group with BRAF-like genetic alterations, so this includes nodules with BRAF V600E mutations, as well as RET PTC fusions and others that are highly associated with malignancy and generally most likely represent classical PTCs, some follicular variants of PTC, and tall cell variant also is associated with this profile. In contrast, if you look at the RAS-like group, which includes RAS mutations, E10 mutations, as well as others, PPAR gamma fusions and so forth, 62% of nodules that harbored RAS-like mutations in this study represented malignancies or NIFP. And there was, some variation in the different types of malignancies that were associated with that profile, including follicular variants of PTC, as well as NIFPs, follicular carcinomas, and so forth. So you can see that depending on sort of what group the thyroid nodule is classified in, that may help you predict a little better what type of cancer or precancerous lesion you might see. Next, I'd like to go ahead and review a randomized pragmatic clinical trial from the UCLA group that compared the performance of the current version of Thyrosiq with the current version of Afirma. In this study, ultimately 372 indeterminate thyroid nodules were randomized to one of the two molecular tests. Because thyroid nodules with negative molecular results are usually managed non-operatively, most of the molecular benign nodules in this study and those performed by others are presumed to be true negatives. For example, in this study, only 12 nodules in the Afirma group and 10 in the Thyrosiq group had corresponding histopathology, whereas most of the nodules with negative molecular testing were assumed or presumed to be true negatives based on their molecular test result. So just one limitation to keep in mind. This limits the detection, of course, of false negatives and to some degree, of course, and then it also makes it essentially impossible to get a true understanding of the sensitivity or negative predictive value for these tests, just because of that caveat that we don't operate on all of these nodules anymore. So I just want to point out that the specificity of both tests was quite high in the study at 80% or higher. And in particular, in comparison to the Afirma clinical validation study, the specificity of 80% was quite a bit higher than the 68% specificity that was determined in that validation study I demonstrated earlier from Patel et al. The positive predictive value was 53% for Afirma and 63% for Thyrosiq. And overall, you could see there was no statistically significant difference between the two tests with regards to any of these statistical parameters, demonstrating that both performed comparably in the study. And overall, 49% of patients were able to avoid diagnostic operations. So this just provides some non-industry sponsored real-world data that Afirma GSC and a Thyrosiq GC perform similarly well as rule-out tests for thyroid cancer, and with regards to their various statistical parameters in this particular study. An important question that I also wanted to touch on is, what are the long-term outcomes of thyroid nodules with negative molecular testing that are followed non-operatively? And this figure is from a multi-center study that included 4 academic sites, including my own. And in this study, we analyzed thyroid nodules that had Bethesda 3 or 4 cytopathology and negative testing using Afirma GEC. And the median follow-up in this study was 2 years. Overall, about 18% of patients underwent resection, and that's comparable to other published resection rates, which range between 5 and 25%. The rate of malignancy for the entire cohort in this study was 1.3%. When we consider only the resected nodules, the rate of malignancy was 7.2%. And we can feel confident that the true false negative rate for this test falls somewhere in between these values. I also wanted to mention that a recent study published by the UCLA group demonstrated that health-related quality of life and anxiety and depression scores do not worsen over time with follow-up of molecular benign thyroid nodules. And this, again, provides some reassurance that when we follow our patients clinically who have benign molecular testing, we're not causing them worsening of quality of life or increase in other parameters like increased anxieties and so forth. Next, I want to mention some data from Ohio State. This was a retrospective cohort study that evaluated 289 thyroid nodules that had undergone testing with Afirma. This study included 160 nodules that were tested using the GEC platform and 129 that were tested using GSC and were benign. Overall, in this study, 13% of nodules were resected. The most common reasons for surgery included symptoms, another suspicious nodule, and or increase in size. And overall, these reasons accounted for 75% of the reasons that patients underwent operations. The median follow-up in the study was fairly short at 8 months. And sorry, just to back up here, that for the entire, looking at the entire cohort in this study, overall 13% of patients, as I mentioned, underwent resection for their thyroid nodule. Looking at GEC, 17% underwent resection, and with GAC, somewhat less at 8.5% underwent resection. The false negative rate for the entire cohort, again, presuming that the unresected molecular benign nodules are truly benign, was 1.7%. When we look at just the surgically resected cohort, the false negative rate was 13%. Again, that would be likely to be an overestimate of the true risk of malignancy. And I do want to point out that there were no malignancies detected in the GSC tested thyroid nodules that underwent surgery. One other important point to point out is that higher risk baseline ultrasound findings, either using the ATA's 2015 system or the ACR Thyroid system, were associated with a higher likelihood of a missed malignancy. So something that I think is important to keep in mind, that if the baseline ultrasound appearance of a nodule is higher risk, that's a nodule you're going to want to watch more closely in the context of benign molecular testing. This is another study. This was a prospective cohort from the UCLA group that looked at 95 molecular benign nodules. These nodules were either tested with the Afirma GEC test or Thyrosiq version 2. So these are the older iterations of those tests. 12 nodules in this study underwent immediate surgery. 11 were benign. 1 represented a NIFT-P. 89% of the remaining nodules had follow-up imaging, and the median follow-up in the study was longer at more than 2 years. Over that follow-up interval, about 7% of nodules underwent growth, 8% had new suspicious features on ultrasound, and 1.4% had both of these findings. Ultimately, 10 nodules underwent delayed surgery in this study, and 4 of those were cancers. The overall false negative rate in this study was about 6%. Something that I think is important to point out from this study is that cancer was detected only in nodules that had changed based on ultrasound follow-up. So again, I pointed out that earlier that more suspicious appearance on the initial ultrasound should make you follow your patients more closely. But if you do see change in sonographic appearance over time to a more suspicious findings, then that also should make you want to do further evaluation for your patient with negative molecular testing to be certain that this nodule is not malignant. So next, I'd like to just circle back to the case that I shared with you at the beginning of this session. This patient had undergone testing with Thyrosiq GC, and here are his results. You can see that overall he had a positive result with a high probability of malignancy, and multiple genetic abnormalities were identified. This included a KRAS mutation, a TERT promoter mutation, copy number alterations, and also abnormal gene expression. I wanted to just mention briefly that the most common primary driver mutations in thyroid cancer include BRAF V600E and PTC, and then RAS in follicular thyroid cancer and follicular variant of PTC. We know that BRAF lacks specificity as a prognostic marker, while RAS mutations, when they're seen alone without other genetic alterations, are typically associated with more indolent disease. However, when we see the combination of RAS mutations with TERT mutations or P53 or other high-risk mutations, this is a marker of a more aggressive tumor that's more likely to behave in a more concerning fashion. And I'm going to give you a few examples of this in the next couple of slides. So the panel on the left shows disease-free survival for TERT mutated versus wild-type tumors in a prospective study from France that included 173 patients. 133 of these patients had PTC, 9 had follicular thyroid cancer. There were others with poorly differentiated thyroid cancer. And they demonstrated in the study that TERT promoter mutations were associated with poor outcomes in the entire cohort, and that they negatively impacted the event-free survival of initially metastasis-free patients without who didn't have otherwise aggressive histologic features. Looking at the panel on the right, you can see that patients who harbored a combination of RAS plus TERT or BRAF plus TERT mutations had much lower disease-free survival in this study by Song et al. Compared to patients who had RAS mutations or BRAF mutations alone, and even more worse disease-free survival than those who had TERT mutations alone. These patients have higher rates of distant metastases as well. And then finally, I want to just describe this case control study, which sought to characterize the genetic profile of differentiated thyroid cancer associated with distant metastases and to validate molecular-based risk stratification. So this study included 62 patients with differentiated thyroid cancer and distant mets, and then a propensity matched cohort of patients who had differentiated thyroid cancer without distant mets, but they were matched according to age, tumor size, and gender. And there was more than 5 years of follow-up in this study. And using Thyrosiq version 3, the genomic classifier, the patients were risk stratified using molecular profiling into 3 different groups. What I want to point out from this study is that among the patients who had differentiated thyroid cancer and distant mets, 66% had a late hit mutation in TERT, P53 or PI3 kinase, in combination with earlier hit mutations in BRAF V600E or RAS. Again, indicating that these patients who experience distant metastases had these higher risk genetic profiles. Lastly, I just wanted to make a note that there are now several targeted therapies in advanced thyroid cancer that utilize molecular profiling in order to determine the basis of the therapy. For example, using dabrafenib, trametinib, which is BRAF-directed therapy in patients with anaplastic thyroid cancer. And so just to quickly leave you with a few key points, First, want to mention that both the Afirma GSC and Thyrosiq GC tests serve as good rule-out tests for thyroid cancer and thyroid nodules with indeterminate cytology. Their clinical performance appears to be comparable, and both offer genetic profiling of positive nodules. It's important to keep in mind that in our thyroid nodules with negative molecular testing, high-risk sonographic findings at baseline or interval suspicious change should raise the level of concern about a missed malignancy. And just wanted to thank you very much for your attention and participation today.
Thank you very much for this eloquent presentation. Now, I'll give the floor to my co-chair, Dr. Alauddin, to introduce the next two speakers.
Thank you very much, Dr. Ali. And I'd like to thank Dr. Sarah Mason for her elegant and informative presentation. And I'd like to remind our attendees to post their questions in the Q&A box, and all the questions will be attended to by the end of the webinar. Now, moving to the next section of the webinar, I'm very delighted that we have an endocrine surgeon with us this time, Dr. James Wu, who is a board-certified endocrine surgeon, and he's an assistant professor of surgery at UCLA. His current research interests include intracellular vesicles in thyroid cancer, decision-making in thyroid cancer, and how to de-escalate care in low-risk thyroid cancer. Dr. Wu is also a member of the American Association of Endocrine Surgeons, and he is a member of the American Thyroid Association. Dr. Wu is going to talk to us about how much surveillance is too much. The floor is yours.
Hi, I'm James Wu. I'm an endocrine surgeon and assistant professor of surgery at UCLA. I really thank everyone at the Emirates Diabetes Endocrine Society for giving me an opportunity to speak during the thyroid webinar program. And today, I'd like to talk to you all about active surveillance of thyroid cancer. And so during this talk, I'd like to review three different things. One, what is the rationale for active surveillance of thyroid cancer? Two, what is the protocol for active surveillance, and what does it actually look like when it comes down to patient care? And finally, the outcomes of active surveillance. So let's begin by, why do we do active surveillance at all? Well, I think it comes back to this, that thyroid nodules themselves are extremely common in the population, but only a very small percentage of these were clinically apparent. Thyroid nodules that you could see or feel on physical exam. And now with the advent of neck ultrasounds allowing us to detect many, many more thyroid nodules and clinically silent thyroid cancers, it's really changed how thyroid disease presents itself to us as thyroid specialists. This is a publication back in 1993 in New England Journal of Medicine, already showing that the number of thyroid nodules that we can unearth by performing neck ultrasounds and or autopsy far outweighs the number of ones that we can find on clinical exam alone. And as you can see, at age 50, half the patients just walking on the street, you will find a thyroid nodule in those patients. And not only will you find thyroid nodules, you will find thyroid cancers. And papillary thyroid cancers, especially small ones, are very ubiquitous in the population. It's just that they don't bother anyone and no one dies from them. This is a great study that illustrates that point. Published in a Journal of Clinical Oncology, this study took a look at patients over 6 decades. And they went through and performed autopsy on these patients that died of car accidents, heart disease, other problems, and looked through their thyroids. And what did they find? 11.2% of people had incidental thyroid cancer when an autopsy was performed. Now, clearly, I think we all understand that 11% of the population doesn't die from thyroid cancer. And so many of these thyroid cancers just are not clinically meaningful. And this is an example in real life. I'm sure we've all seen this figure and this chart, where in South Korea, they decided to do a thyroid cancer screening program by doing a neck ultrasound on regular healthy people. And of course, as they did more ultrasounds, they found more thyroid nodules, did more thyroid biopsies, and found an exponential rise in the incidence of papillary thyroid cancer. We did the same thing in the United States. You could see here from 1973 to 2000, this dramatic rise in thyroid cancers. But you can see that it's not the follicular or polydifferentiate thyroid cancer rising, but just the papillaries. And more specifically, it's these papillary thyroid cancers that are typically smaller in size, under 2 centimeters, that account for the dramatic increase in thyroid cancer diagnoses. This is yet another example of a study published from Canada looking at their National Cancer Registry and showing that the incidence of thyroid cancer dramatically rose from the 70s to 2010. And yet, despite all this, the mortality in men and women from thyroid cancer did not change. So we are finding more thyroid cancers, but not more people were dying from their thyroid cancer. And here's the more mortality data from the United States in the same similar period. And despite all of these thyroid cancers that we are now detecting and treating, the amount of people dying from thyroid cancer did not go down. So were we finding cancers earlier that may have become a problem later? Based on this data, it looks like no. And if anything, when you look at the results of this paper published in JAMA, the amount of the mortality in thyroid cancer just seems to be increasing in certain cohorts. And taking all of this data into consideration, in the United States, our Preventative Services Task Force has recommended against screening for thyroid cancer, meaning that synthesizing all this information, it is better to leave papillary thyroid cancers unfound in people than to aggressively look for thyroid nodules and thyroid cancers with a screening ultrasound, because ultimately we will do more harm than good by finding these small papillary thyroid cancers. And unfortunately, sometimes we will get an ultrasound, we will find a thyroid cancer, and then it puts the physician in a difficult position, because when a patient has a very low risk, small thyroid cancer, or even just a small risk nodule, most physicians are worried about a missed diagnosis, or they're worried about the thyroid cancer becoming worse, a missed opportunity to treat it metastasizing to a lymph node. And because of that, they routinely recommend that everyone go for a surgery to prevent that outcome. And that here's the dilemma that we're facing. Because we're worried about missing this diagnosis, we commit all the patients that we meet to a surgery. And that puts those patients at risk for nerve injury, low blood calcium due to hypoparathyroidism, or financial toxicity, the cost of the surgery, the recovery from the surgery, the time off work from the surgery. And so because we're worried about a very rare missed event, we are consigning many people to the risk and costs of surgery. And so there has to be a better way to treat these and manage these low-risk thyroid cancers. And I think this is the reason why we do active surveillance in some patients, because with all this data that we've shown, small thyroid cancers can grow slowly and some can grow not at all. Many of them do not cause death and are clinically silent throughout the course of our lifetimes. And by treating all of them, we are over-treating patients. And so less is more for these low-risk cancers. And here are the numbers again. If we do thyroid surgery on everyone with a sub-centimeter thyroid cancer, 5 to 7% of those people are going to have temporary hoarseness. 0.5%, or 1 out of every 200, will have permanent vocal cord injury. And of course, if we perform a lobectomy, then 13 to 50% will need to take daily thyroid hormone from then on. And of course, if we do a total thyroidectomy, then 100% of those patients will need thyroid hormone daily. All right, so with that in mind, I just want to talk a little bit about what is active surveillance. I feel like this is a new concept for many thyroid specialists, and some may be uncomfortable just because they cannot imagine what the active surveillance may look like. Well, when we are thinking about active surveillance and thinking about how to treat low-risk thyroid cancers, I don't think that we should frame things as things being the right answer or the wrong answer. For low-risk thyroid cancers, there's many ways to treat it: active surveillance, thyroid lobectomy, total thyroidectomy, probably even radiofrequency ablation, other treatments. And so the way we should talk about it is whether a treatment is appropriate or inappropriate for a patient, and whether a treatment may be ideal for that patient. In order to make that determination, whether a patient is ideal, appropriate, or inappropriate for active surveillance, we need to take in consideration 3 different domains: the patient characteristics, tumor characteristics, and characteristics of the medical team. For the patient, patients who are younger will have lower risk tumors, but patients who are very advanced in age may be able to be observed and not undergo a surgery by the time of their life expectancy. Patients who are not anxious about watching a cancer and very anxious about surgery are better for active surveillance. And of course, patients must have the ability to follow up. And if patients cannot reliably come back for neck ultrasound, then it is not safe to ask them to watch their thyroid cancer. When it comes to the tumor, we obviously are more comfortable observing tumors that are smaller, but in addition to size, we have to pay attention to the location. It has to be able to grow somewhat and not endanger the recurrent laryngeal nerve. It must not be at risk for extrathyroidal extension. These things are different based on where the tumor is. And finally, the medical team. If the patient is somewhere where they cannot access a thyroid specialist, somewhere where they cannot easily get neck ultrasound, then those places are not good places to have active surveillance. Here are just some examples of different patients that may be good or bad for active surveillance. A 65-year-old woman with a 1 centimeter thyroid cancer who's very nervous about undergoing surgery, that's probably an ideal patient that can undergo active surveillance. However, a slightly younger woman with a slightly larger tumor, although still eligible, we will observe thyroid cancer is up to 1.5 centimeters in size. But in this case, if it's near the capsule of thyroid, distorting it, and they also live far away from the university, then they're probably better suited for surgery rather than surveillance. And of course, when tumors are over our size limit, then they should have a total thyroidectomy. So when we choose to do it, well, what is it? It's as simple as making an agreement with the patient that they need to come back and see us for neck ultrasounds and a physical exam, the neck ultrasound being most important. So at first, we'll perform the neck ultrasound every 6 months. And then as time goes by, if it shows interval stability, we can make the ultrasounds less frequent. During this time, we also check a TSH level and maintain a low normal TSH with a goal less than 3. That's not evidence-based. It's more just thinking that if we allow the TSH to be greater than 3, it may give the nodule too much stimulus to grow. And then during these neck ultrasounds, we want to monitor tumors not by 2 dimensions, but actually in 3 dimensions by volume. And there are easy ways to keep track of that over time. We do our ultrasound. We use a very low-tech, anyone can do a spreadsheet to measure the dates, and we record the measurements of each nodule in 3 major axes. This is a Excel sheet that you can find on the internet. It was developed by the practitioners at Kuma Hospital, who were the pioneers of active surveillance for thyroid cancer. And so it's free to use, easy to use, anyone can use it. And all you need to do in this Excel sheet is enter in the date, enter in your measurements of the 3 axes that you perform on ultrasound, and then it will automatically generate these graphs for you that calculate the volume and show an approximate line over time. And this is valuable information for the patient because as you add more ultrasounds and measurements, you get an idea of not just where the tumor is now, but where the tumor is heading. The cells tend to be relatively uniform in these thyroid cancers, and so we should have a predictable rate of growth after enough measurements. And it'll allow you to tell patients who are especially young, their doubling time, that in this many years, your tumor is likely to be twice as large, and that may help them make the decision of surgery sooner than later. Or it may show a completely flat growth curve, in which case it'll give us more confidence to continue observation for longer. And I think in all of this, it is really important to keep in mind the goal of active surveillance. The goal of active surveillance is not to save people surgery, but it is to reduce overtreatment. But in some patients, surgery is still the best treatment, and we should not have any qualms about moving on. And these can include things like patients finding surveillance too cumbersome, that their life circumstances change and they cannot regularly come back for neck ultrasounds. These are perfectly reasonable reasons to have a surgery, as well as patients that tell you, or you can see, that their anxiety over the observation is impacting their quality of life. And if they would do better just having a surgery, then those patients should move on to having surgery. And of course, we also have our own stops. If we see that the tumor increased by volume by 50% in the course of the first 3 years, that happens to 18-15% of people, we will recommend surgery and stopping active surveillance, as well as if we find any evidence of the tumor spreading to nearby lymph nodes or showing signs of extrathyroidal extension. That happened only in about 0.5% of patients on active surveillance. And again, at any time, patients may request to stop surveillance at any time. This paper and this slide really emphasizes who we should not be offering active surveillance to. And as we mentioned in tumor characteristics, location is very important. And that's why if you are going to be offering active surveillance, you need to be comfortable with reviewing ultrasound images and looking for this issue. So at Memorial Sloan Kettering, this paper by Dr. Tuttle and Ganley looked at all the patients who had evidence of recurrent laryngeal nerve invasion, a very rare but devastating event in thyroid cancer. Now, they reviewed 120 cases, and of these, extrathyroidal extension was only seen on ultrasound in 25% of cases. Vocal cord paresis was only clinically apparent in 30%. That means many patients had recurrent laryngeal nerve invasion with no signs of extrathyroidal extension on ultrasound, and their voice was totally normal. And this included many lesions that were under 2 centimeters in size. And what was common about many of these tumors is that they sat in the right or left paratracheal space, as you can see in these ultrasound images above me. And so when tumors are located in this region very close to where the nerve territory is, it is important to tell those patients that it's better to do surgery than observe. And this was true for any lesions greater than 0.9 centimeters. Smaller than 0.9 centimeters, even in this location, tumors did not demonstrate any invasion of the recurrent laryngeal nerve. Okay, so now I want to talk to you about what the outcomes are. Because even though people may know the rationale for doing it, may know what it looks like, they still may be very skeptical or worried about what may happen. This is where I want to start us off. This is a paper that I published with the other members of the UCLA Endocrine Surgery Research Group. And we did a survey of members of the American Thyroid Association. These are all physicians that belong to organizations specifically interested in thyroid and thyroid-related care. And we asked them and a very straightforward case of a micropapillary thyroid cancer, 8 mm cancer, no signs of any high-risk features on ultrasound, normal patient. What do you recommend? Observation, which is active surveillance, a thyroid lobectomy, or total thyroidectomy? And you can see here that among ATA members, 35% chose observation, another 60% chose thyroid lobectomy, and slightly under 10% chose total thyroidectomy. Why disagreement on how best to manage a very indolent disease? And when we then ask these same providers to estimate the risks of doing active surveillance as a way of trying to see if this impacted their decision making and to recommend it or not, this is our histogram above me here, where the risk of disease progression of cancer going to the lateral neck nodes or distant metastases go from 0% to 100% on the bottom axes. You can see most providers felt that there was 0% risk with active surveillance, but you can still see that a significant proportion of ATA members thought that there was risk between 20 and 80% of lymph node metastases during active surveillance. I wanted to share that with you to let you know where we start at, because this is, the honest truth of what has happened in these large-scale, granted uncontrolled studies of active surveillance. Here is the data from Memorial Sloan Kettering. They observed 284 patients with active surveillance. All of these patients had thyroid cancer. They were observed. There were no cases of distant metastases and no deaths due to thyroid cancer among these patients. Now let's look at the amount of patients that ultimately needed surgery. So starting in figure 1, you can see that over the course of 5 years, at the end of 5 years, about 12 to 13% ended up having one of the dimensions of their thyroid cancer increased by more than 3 millimeters, which means that for 85+%, there was no change of more than 3 millimeters in any dimension of their nodule. When you look at increase in volume, about 25% met surgical criteria over the course of 5 years of increase of their nodule volume by 50%. That means that 75% of patients watched with a thyroid cancer had overall stable disease. % of patients developed disease in adjacent lymph node, no distant metastases, and no deaths from thyroid cancer. Again, compared to our initial survey where many physicians felt that the risk was between 20 and 80%, the real risk in 5 years from these studies, 0.5%. And if you look at the patients who had immediate surgery, 0.2% still had lymph node metastases during the observation period. suggesting that upfront surgery is not fully protective, even in these low-risk micropapillary thyroid cancers. And of course, the patients who underwent surgery had a very low but real rate of permanent hypoparathyroidism, 1.6%, and then a real rate of hoarseness, 0.2%. And of course, many of them ended up needing thyroid hormone supplements because of their surgery. One final study, this is similar experience in Korea. And as you can see that this kind of mirrors the other two studies showing that there's a large percentage of patients who have stability of their tumor volume over time. Some even have a decrease in their size, with only a small 14% of patients who have an increase in the size of their thyroid cancers during observation. Now, the American Thyroid Association recently published their systematic review on this topic. They do point out that the quality of current clinical data, including many of the studies I showed you, is currently low quality data because these are all uncontrolled studies. What they can conclude is that young patients with low risk papillary thyroid cancers that are under a centimeter in size, that active surveillance does appear to have similar outcomes to surgery when it comes to mortality, recurrence, but they do say that they are reluctant to make a strong conclusion or strong recommendation because the data quality is low. And for other patients who are older or have cancers larger than a centimeter, there's just insufficient data to make a conclusion on that at the moment. I think it does bear mentioning that when patients hear about active surveillance and they're educated about the existing data, this is a study done in Canada by Dr. Saka and her group. And what they found was that when a patient is given educational materials, informed about surgery and active surveillance for their low-risk papillary thyroid cancer, that the majority, 71% of patients chose active surveillance. And when spoken to them, 98% of these patients had a high satisfaction with this decision. They were not nervous about it. They felt good about what they chose for themselves. And so I think that we should also keep this in mind, that we should avoid being paternalistic. And as long as it's safe and it's what patients prefer, because they really strongly prefer avoiding a potential surgery, I think this is important for us to consider when considering whether or not to employ active surveillance. So in summary, and to answer the question, how much active surveillance is too much? Well, it's clearly not for everyone. It is a safe alternative to surgery, especially in patients who are young with papillary thyroid cancers less than 1 centimeter in size. We can also reassure patients who are interested in active surveillance that if they have low risk papillary thyroid cancer, that all the current studies have shown that there are no evidence of distant metastases or thyroid cancer deaths, at least when performing active surveillance over 5 years. And that the majority of these nodules will stay the same size, with only a minority getting larger and needing surgery. Now, for tumors that are larger in size or patients who are slightly older, slightly more data is needed before we can make a strong conclusion on what is appropriate. We can say when it is not appropriate, which is when there are tumors located in the right or left paratracheal space, when there are tumors located near the capsule, and in patients who cannot be regularly followed up with neck ultrasound. Again, we should always consider patient characteristics, tumor characteristics, and hospital characteristics before recommending active surveillance. Thank you so much for your attention and the opportunity to talk. Happy to answer any questions during the Q&A session a little bit later on. Thank you so much.
Thank you so much, Dr. Wu. During Dr. Susan Mandel's presentation, she actually mentioned that there is some degree of discordance between sonographers, even especially if they're from different institutions. And to reduce that discordance or disagreement between sonographers, she suggested in the future directions that we should go for artificial intelligence that helps with improving the disagreement, and at the same time, it helps evaluating or risk stratifying nodules that are difficult to risk stratify. Our next talk is about artificial intelligence. Could it improve the diagnostics of thyroid nodules? And it's going to be presented by Dr. Nikita Bozdiev. He's an assistant professor in the Division of Bioinformatics and Personalized Medicine at the Division of Endocrinology at University of Colorado. He's an endocrinologist, and his main interests are in the field of thyroid cancer, genetics, artificial intelligence, and in developing machine learning applications for management of thyroid disease. The floor is yours, Dr. Nikita.
Hello, I am delighted to present about artificial intelligence and how it can improve the diagnostic of thyroid nodules. During this talk, I will mention a couple of commercial tests and commercial applications, and I would like to disclose that I have no financial relationships to any of those companies. The objectives from today's talk is to define what artificial intelligence is and a subset of artificial intelligence machine learning, to explore the benefits and downsides of AI-based tools, why we are even interested in exploring those. And the most interesting part, to learn about existing and emerging tools and the applications of artificial intelligence for evaluation of thyroid nodules. So what is artificial intelligence? The classic definition introduced by John McCarty is that AI is a science and engineering of making intelligent machines, especially intelligent computer programs. The goals of implementing AI is to develop systems that think and act like humans and do this rationally, and importantly, systems that can help us to solve the problems. In healthcare, we have no desire, no hope to develop AI systems that would replace human clinical providers. But there is a great potential for AI to help us to perform better in our clinical tasks. So this slide shows Gartner's hype cycle for artificial intelligence technology. According to the company, each transformative technologies goes through a couple of steps in its life cycle, starting from its invention, going through the peak of inflated expectations, trough of disillusionment follows those inflated expectations. But ultimately, that technology gets to the plateau of productivity phase. That's when we are well familiar with it, we are comfortable using it, and our clinical tasks benefit from using this technology. With red arrows, I highlighted 3 technologies which are particularly relevant for the thyroidology and healthcare field, which is machine learning, a subset of machine learning that's called deep learning, and an application of deep learning, which is computer vision. This Venn diagram illustrates the relationship between these terms that I have just mentioned. Artificial intelligence is a very broad field, which includes applications such as robotics, interpretation of spoken or written language, but we are mostly focused on a subset of it, which is called machine learning. Machine learning is a field of a data science which allows us to train computers to learn from the data. It could be any data, including clinical data and clinical imaging. Finally, in the past 12 years or so, deep learning learned gained popularity, which is one of the machine learning methods, because deep learning turned out to be highly effective for computer vision tasks and the other healthcare related tasks. And computer vision is a subset of artificial intelligence, which allows us to train computers to work with imaging data, not as different from how we see the world around us. So this is an example of a machine learning task. When we build some kind of a machine learning model, deep neural network in this case, we have a training data, such as thyroid ultrasound images, and we hope to train this deep neural network to provide a useful output, such as presence of the high-risk features on the image or a probability of cancer. A very brief introduction of how those artificial neural networks work. It's essentially conceptually not different from the other machine learning applications, such as linear regression. The neural network is a combination of what we call artificial neurons, which are simple formulas which do a nonlinear transformation from the input number into the output number. And the power of the artificial networks comes from ability to build a very large connected networks with a great ability to learn from the input data. In practice, for the computer vision tasks, such as interpretation of medical imaging, we use a subset of artificial neural networks, which is called convolutional network. And convolutional network has an ability to scan through the image and learn a simple features of it, such as horizontal lines, edges of the nodule, bright pixels, punctate echogenic foci. And as we build the model and add more and more layers to it, then each subsequent layers learns a more abstract representation of what a thyroid nodule constitutes, what is a high-risk feature is, and ultimately can give us a useful prediction, such as cancer, no cancer, high-risk features, no-risk features. So this slide illustrates of how much progress has been achieved into developing computer vision algorithms in the past 12 years. ImageNet is a large database of natural images. Those are the images of cats, dogs, cars, humans, and there have been a challenge presented to the data scientist is to train a computer to classify correctly those images into corresponding categories. Horizontal line here shows that humans are not perfect into making those calls either. There is some error rate when human operators are asked to classify those images as cars, dogs, and humans. And starting from 2015, computers started outperforming humans. And that progress has continued over the 5 years. And at this time, on this particular task, computers do really well. So why do you even bother of training the computer to do something that we do reasonably well in our clinical practice? This, I think, are the features of artificial intelligence which are helpful. First of all, computers are consistent. There is a bulk of high-quality literature suggesting that endocrinologists, radiologists, and cytopathologists, we are not very consistent when we do interpret imaging or cytology slide. There is a great deal of interperson and even within interpreter variability. And the computers, if you give them the same data, most of the models will produce exactly the same answer. Computers can work with a big data of any type. One of the examples is transcriptome-wide gene expression data. Modern methods such as RNA sequencing produces gene expression data for about 50,000 genes, which is not something that our brains can easily comprehend. AI tools are high throughput. It is possible to process hundreds of thyroid ultrasound images in a matter of seconds, which can help radiologists with the throughput. And the most exciting features of AI is the potentially the computers can learn characteristics of an image of an object which are not obvious to the human mind. And one of the examples that I am going to briefly discuss is how we can learn using machine learning from germline variants in our genome, and how that can help us to predict the risk of developing thyroid cancer. So enough is apologies. So before I go any further, I would like to mention some downsides of the AI applications. I think the greatest deficiencies of AI is that it's usually trained for a specific task. It's what we call a narrow AI. And in that sense, the AI tools lack what we call clinical judgment or intuition. As an example, we can train a computer vision algorithm to recognize thyroid's features from the thyroid nodule. But if we present that algorithm with an image of thyroid lymphoma, we generally would not have any high-risk thyroid features. The diagnosis would be incorrect. While we, as clinical providers, most likely recognize that there is something odd about that image and recommend further workup. AI applications are very dependent on the quality and quantity of data that is used to train them. For example, it probably would take about 50 thyroid ultrasounds to train a fellow to recognize risk features for the thyroid nodule reasonably well. It takes thousands and ideally hundreds of thousands or millions of images to train a well-performing AI algorithm. There is an issue of generalizability. Computers work well on the data that has the same characteristics as an input data they were trained to recognize. It is quite possible that once that data characteristics change, for example, a hospital buys a new ultrasound machine, then the performance of AI applications would suffer. And finally, the machine learning models are frequently criticized for being a black box. It's not obvious how they work. For example, if an algorithm assigns 75 probability of malignancy to a particular thyroid lesion, frequently we have no idea of how that number has been generated. So now going to a most interesting part of the talk is what actually are the applications of AI in thyroidology. And I like to classify those into groups. Mature applications, which are those which are already available for us as clinicians to use, and the emerging applications, those which are currently being developed or tested in research centers, but generally they are not ready yet for the general practice. For mature technologies, I will mention a software which assists radiologists and endocrinologists in interpreting thyroid ultrasound images and identifying high-risk features. This software is capable of calculating thyroid points, estimating ATA sonographic risk patterns, and do all sorts of helpful predictions which will increase our ability to interpret ultrasounds and increase radiologist throughput into generating more reports in a smaller amount of time. And machine learning applications are used extensively for the molecular diagnostics of indeterminate thyroid nodules. It's an integral part of molecular diagnostic tests that we routinely prescribe. Speaking of emerging technologies, I will briefly mention AI cyto and histopathology, how we could use computers to leverage germline genetics to estimate the risk of thyroid cancer. And a curious task, which is not directly related to the diagnosis of thyroid nodules, but helpful for the management, is how we can better prescribe levothyroxine dose to the patients who underwent thyroid surgery. So in the next couple of slides, I will illustrate a couple of software applications designed to help interpreting thyroid ultrasounds. To my best knowledge, all of these applications have been FDA approved for marketing, so they are available for purchase and use. I think the oldest one is MCAT UT software, and an image on the left illustrates what it can do. The software can automatically identify region of interest and outline borders of a thyroid nodule, and it attempts to detect features which we are interested in, such as echogenicity, presence of punctate echogenic foci, texture margins, etc. There is a built-in calculator in this software which will assign risk of malignancy based on current clinical risk stratification algorithms, such as American College of Radiology TIRADS or American Thyroid Association risk patterns. There is a number of publications which evaluated prospectively the MCAT UT tool. And this table on the bottom shows the results from one study that applied this tool to 234 thyroid nodules, which are of TIRADS grade 3 or 4. And then the authors compared performance of ultrasound doctor, which this is what UD stands for, versus automated computer-assisted diagnosis system and a combination of a human doctor with a computer, the ability to diagnose thyroid cancer from the ultrasound images. The metric that was used is called area under receiver operating characteristic curve. Greater the better. The ideal tests have that area equal to 1. As you see, the authors showed quite an improvement in our ability to diagnose thyroid cancer when the computer-assisted diagnosis system has been introduced. The second system that I would like to mention is a Samsung S-Detect. It's built into the Samsung ultrasound machines. I think this is the only system that has been prospectively evaluated in a clinical trial, in a formal clinical trial. And the results from that trial are actually quite interesting. It turns out that the system, the automated system, will outperform inexperienced radiologists in diagnosing thyroid cancer, but it falls short when it has to compete with highly trained, experienced radiologists, which makes sense. The two other systems which I was able to find is MetaThyroid. So MetaThyroid is designed to be built into the ultrasound machine and do a real-time analysis of thyroid nodules acquired through with an ultrasound probe in a real time and assign a thyroid score. And Koya's DS thyroid system allows an operator to outline a region of interest, which is shown here on the left. And then the computer calculates high-risk features such as composition, shape, and the others, and assigns a risk based on TIRADS risk stratification algorithm. So all 4 tools that I've mentioned, they are relying on existing clinical risk stratification algorithms such as TIRADS. And those algorithms were designed to be used by humans. Theoretically, there is a possibility that when released from the boundaries of these risk stratification tools, allowing to learn independently the risk features from the images, the artificial intelligence would perform better. And this is an active area of research. On the bottom, I have highlighted AUC curves for the 3 tools which have been developed with this in mind. 2 of them were developed in China, and the one on the right we are working on at the University of Colorado. And those tools, which are not designed to predict TIRADS features or non-thyroid non-high-risk features, but instead they are designed to assign a probability of malignancy. They perform reasonably well with AUC of around 0.9. And what we are interested in is answering the question, is it possible to develop a classifier which would have such a negative predictive value that it would match fine needle aspiration biopsy, because that is what would make such a tool clinically relevant, where we could say, well, this nodule is so unlikely to be cancerous that performing a fine needle aspiration of it is unlikely to provide us with any additional useful information. And this way we could reduce the number of invasive procedures and distress that we cause to our patients by performing it. I would like to show a couple of images from our research. We did explore what AI algorithms are good for and where they fail, because I think this is important to realize a full potential in the future from AI-based thyroid nodule diagnostic tools. And we found that the nodules which are assigned the highest probability of malignancy by the computer, they are almost uniformly classic papillary thyroid cancers that have unambiguous high-risk features such as microcalcifications and hypoechogenicity, as illustrated on this image. And truthfully, there is a little diagnostic dilemma in those cases. I think both the computers and endocrinologists and radiologists would have an easy time recognizing that these nodules needs evaluation and are likely to be cancerous. But I think it's more interesting is to look at which nodules are considered by a computer to be very likely benign. And we have discovered that these nodules fall into two categories. Those that are fully cystic, like the number 14, and also the spongiform nodules. And we know the spongiform nodules are very unlikely to be cancerous. And this is an illustration of how the AI was able to learn the same high risk and low risk features that we recognize and built into current clinical risk stratification algorithms. I think the most important is to look at the cases where the artificial intelligence fails. These are the nodules where the computer decided that these are such a low risk nodules that fine needle aspiration is unlikely to give us a benefit. But we know from surgical histopathology that these are actually cancerous nodules. And these are 13 nodules in our data sets that were incorrectly classified, that were false negatively classified by the AI-based tools. And as you can see, all of these nodules belong to a different, difficult to diagnose subtypes of thyroid cancer, such as follicular thyroid cancer, hurdle cell, follicular variant of papillary thyroid cancer. And I think most of these images, maybe except for number 6, do not have any classic characteristics that we would look for in a clinical practice to diagnose thyroid nodules. So this slide illustrates that AI-based tools would suffer from the same deficiency that we have in our existing clinical risk stratification tools, such as ACI TARADS, that malignant nodules that of certain subtypes that are not classically associated with high-risk features such as microcalcifications or hypoechogenicity would not be correctly picked up by these algorithms. And in clinic, we get around of this deficiency by just biopsying everything that looks low risk, but has a certain size, like more than 1.5 centimeter. So I'm going to switch gears a little bit and talk about another currently accepted application of machine learning for the diagnosis of thyroid nodules, which is molecular diagnostic tools. In our clinic, we use 2 of those, a former gene sequencing classifier and Thyrosiq version 3. And in fact, both of these tools rely heavily on machine learning as a subset of artificial intelligence. So this slide was taken from a flagship, a former GSC paper, and it shows that basically on every step of classification algorithm, it uses some kind of machine learning. Particularly this ensemble model part, it actually a combination of 12 independent classifiers which all contribute to the ultimate decision whether the former GSC is called suspicious or benign. The biggest advantage of using this approach is that we could make sense out of the large volume of data, such as mRNA expression data, which would not be comprehended easily by the human brain. The disadvantage is it's an example of a black spot model, when we don't really know what are the genes that are factored into calling something suspicious and why a certain probability of malignancy has been assigned to the thyroid nodule. This is a similar slide for another molecular diagnostic test, Thyrosiq version 3. Authors have provided us with this formula, which helps to understand how gene classification score is calculated. It's somewhat more interpretable than for a former GSC. We know that presence of some single nucleotide variants, gene fusions, copy number alterations are factored into the gene classification score, but also gene expression analysis is another contributing factor, which is also somewhat black box. So now I want to dive into a future of AI in thyroid nodule diagnostics and discuss some of the emerging applications where computer-assisted diagnostic systems and machine learning could be helpful. And one of those fields is AI cytopathology. This is one of the recently published papers which trained, where the authors trained computer to analyze scanned slides generated from fine needle aspiration biopsies. And the computer was asked to assign those slides into one of the test categories, which we use in clinic. And I think this slide illustrates the efficiency of machine learning algorithm versus the cytopathologist. When you look at the benign category for ground truth benign cases and for malignant nodules for malignant nodules, it's clear that the cytopathology was more confident in the calling something unambiguously benign or malignant, while the machine learning algorithm resulted in more indeterminate calls, such as AUC for benign cases or suspicious for PTC for malignant nodules. So in summary, this technology is not yet ready for use in general practice, but I think it's going to improve as the time goes. And one of the applications where AI would definitely excel is identifying adequacy of fine needle aspiration specimens without the need for the human pathologist to look at the slides. So in the last 3 minutes, I'll talk about two highly innovative areas of where we could use artificial intelligence and machine learning to help with management. Those are heavily experimental, of course. And one of the applications is to use germline genetics to assess thyroid cancer genetic risk. It turns out that thyroid cancer is a complex genetic trait. And I'm talking about differentiated thyroid cancer, not so much medullary thyroid cancer, which we know is associated with germline high penetrance RET mutations. And differentiated thyroid cancer, such as papillary thyroid cancer, in terms of its genetic background, it resembles more traits such as diabetes, which means there is not any one single mutation that makes you develop a cancer, but there are there are multiple genetic variants, each of them contributing a little bit to the risk of developing thyroid cancer. And if we could learn what these variants are, we potentially could identify individuals who are at risk for developing thyroid cancer or having a malignant thyroid nodule. So from epidemiology studies, we know that about half of thyroid cancer susceptibility is accounted by genetic factors. In clinic, when my patients ask me, why me, why I have developed cancer and the others don't, I frequently answer that at least for half of that risk, you can blame your parents. it turns out that female relatives of patients with papillary thyroid cancer have approximately threefold higher lifetime risk of developing the disease when compared to general populations. We, in the Colorado Center for Personalized Medicine, we are working on developing thyroid cancer polygenic risk score, which would identify those high-risk genetic variants which we inherit from our parents and build it into a machine learning tool which would assign a risk of thyroid cancer to each genotyped individual. And this plot on the right shows that a bottom 10% with the lowest polygenic risk score for thyroid cancer have a prevalence of thyroid cancer of about 0.5% in our Colorado Center for Personalized Medicine cohort. But those who have the highest polygenic risk, they have about 7-fold higher risk of developing thyroid cancer. This technology is not yet ready for the clinical use, but we believe that combining this with artificial intelligence applications which leverage ultrasound imaging data, we could improve prediction and bring it to the level where it could be useful in clinic. On the very last slide, I will mention one of the other projects that we are working on, where we use machine learning to predict levothyroxine dose, which should be prescribed for the patients who underwent thyroidectomy. And we believe from our preliminary data that such a tool would outperform our standard of care when we prescribe levothyroxine based on weight. In conclusion, artificial intelligence and machine learning are used in clinical practice to interpret thyroid ultrasound and for molecular diagnostics of thyroid nodules with indeterminate cytology. It's already available for us to use. But there are a number of emerging AI applications, such as classification of thyroid nodules agnostic to the existing clinical risk stratification algorithms, AI cytopathology applications, clinical applications of polygenic risk score, and even machine learning assisted levothyroxine dosing for patients who underwent thyroidectomy. Thank you for your attention.
Thank you very much, Professor Buzdayev, for your interesting lecture. Now I'd like to invite all the speakers to the Q&A session.
Dr. Aladdin, maybe I can start with one question while encouraging people to put their question through. The question is for Dr. Sarah, if I may ask this question. Assuming that you have a case with the patient had by ultrasound, high-risk ultrasound features, and the FNA resulted, the result of the FNA is indeterminate, US plus. Which, for molecular testing, would you consider Afirma or Thyrosiq? And why would you do so?
Sorry, you're on mute.
You're on mute.
You're on.
Okay, sorry about that. I think it depends on your goals of molecular testing. So if you have a high-risk thyroid nodule with indeterminate cytopathology, I think you could make an argument that that patient could move forward with thyroid surgery. But depending on your patient preferences, if they're strongly would like to avoid surgery, or if the thyroid nodule, again, it's not very big in size and not one where you'd otherwise need an operation, then you could use one of the two molecular tests. And in this situation, again, because you're using them for their rule out likelihood, you could use either of the two tests, but knowing that nodules that have higher suspicion pattern on that initial ultrasound, as shown in the Ohio State data, will have a slightly higher post-test probability of malignancy if the molecular testing is negative and you need closer follow-up for that person. The other utility, if you were thinking that you wanted to just know more about that nodule and potentially what the genetic abnormalities might be present in it, to maybe better define what extent of surgery you wanted to do, then I would, in that context, prefer the Thyrosiq test or, a Afirma expression atlas as an add-on, just so that you can get the genomic information as well. So I think it depends a little on your patient's goals and your goals and the size of the nodule, but those would be kind of the possible options.
Would it be fair to say that both are equally, and from the diagnostic point of view, they are quite equal? When it comes to prognostic approach, probably you will learn a little bit more from Thyrosiq more than with Afirma. Is that fair to say?
Yeah. With Thyrosiq, the test is the genomic alteration. So it's built into the test that you will receive that information. You also can identify, as I mentioned in my talk, the TERT promoter mutations, which are a marker for more aggressive thyroid malignancies, which you wouldn't be able to pick up using expression atlas since it's RNA based. So I think there's no direct head-to-head comparison of the two tests in terms of their prognostic abilities, but my feeling is that since TERT is one of the few mutations we know has significant effects on prognosis, I like to know if it's present, so I prefer Thyrosiq for that reason, since it might change what I would do.
Thank you.
Thank you. A question for Dr. Wu. There is a question from the audience. Is there any specific size limit for the nodule in which you go for surgery directly regardless of the FNA result?
I think if we're talking about what is the size cutoff that is acceptable for active surveillance, I don't think that there's a strictly established size threshold. I think at places that are a little bit more aggressive about active surveillance, like Memorial Sloan Kettering, Cedars-Sinai, I think they may push the limits a little bit more and accept nodules that are 1.5 centimeters. And if it goes from 1.5 up to 1.7, 1.8, they may continue to watch it as long as the velocity of growth is slow. On the other hand, when I started at UCLA trying to do active surveillance for some people, I think the endocrinologists are obviously less comfortable, in which case we probably will be comfortable watching lesions that are less than a centimeter and not push the size limit. I think more data is really needed to know what is appropriate or not.
I think the question meant the person asking the question is effectively, if you have a size nodule like close to 4 centimeters, and then it's by ultrasound, it's like in the Thyroid 3 category, which is like a little bit of moderate suspicion. And then you do the cytology, comes back, the FNA comes back as Bethesda 2. Is there a size limit that you would say 4 centimeters is the size where I have to go for surgery, or less than 4 centimeters? Yeah.
I see what you're saying. Well, for Bethesda 2 lesions that are benign, people are always worried about a false negative sampling rate. But I think that even in lesions that are 4 or 5 centimeters, the false negative rate is still going to be in the single digits. And I think you probably could observe with ultrasound as long as there's no signs of lymph node invasion, extrathyroidal extension. And I think once it gets to that size, the other question is whether the patient is symptomatic from it or not. Right. Because if the patient is symptomatic from a large thyroid nodule, then you would still remove it without regard to suspicion of malignancy.
Okay.
There is a question here, Dr. Sarah, about the risk of thyroid cancer in patients with Graves' disease. How high is it, and whether you go for FNA in those patients, regardless of the technician scan, whether it's a hot or a cold nodule?
Yeah, sure. I'm happy to answer that. There's, some studies that have shown there might be a higher risk of thyroid cancer in the context of Graves' disease, but it's not consistent, and there's not generally high quality data. They're mostly retrospective studies. Personally, it affects the patient's management if you detect that they have a thyroid cancer at the same time as, Graves' disease and hyperthyroidism. And so that in itself, I tend to sometimes have a little bit lower threshold to biopsy in those patients because it'll affect how I'm going to manage the person. For example, if they had a hot nodule in the context of Graves on a thyroid uptake and scan, I don't think I would biopsy that because I would, that you can see people who have uncommonly a hot nodule plus Graves' disease. I always say the name wrong, but like Marine-Linehart syndrome. But if it was, a cold nodule, or if you didn't do a scan and it looked certainly high risk for thyroid cancer, then I would biopsy it in that context. Again, just because you may favor surgical management if it instead of radioiodine treatment or methimazole.
Maybe I can put the question for all the speakers, and in the setting of a hot toxic nodule or a multinodular toxic nodule. The guidelines have been saying that the risk of malignancy would be quite low, especially in the setting of what hot toxic nodule.
Right.
But if we look at the literature, there is some variability, and some studies have shown, and actually it can go from less than 3%, less than 5%, to some series can reach maybe 10% or maybe 15%, depending on the population you're addressing. Are you still, all of you, in the feeling that really hot nodule or within a multinodular toxic nodule, it's safe to consider it in that? What if the ultrasound features are suspicious of that, some of those nodules? Anyone?
Yeah, I think you have to look at the ultrasound features. What you'd be missing, again, is usually a functioning follicular thyroid carcinoma, right? Is what generally you'd be concerned about. Those are the most common cancers that will actually be functioning and produce hormone. And those actually typically on ultrasound have a more innocuous appearance, usually isoechoic, hyperechoic, and solid, and don't look like a PTC. So it's not a scenario I find myself in very frequently. I think I would have to weigh that, again, that ultrasound appearance against the functionality. But typically the ones that are functioning cancers will look a lot like the benign functioning nodules anyway. So it's tough, but generally the risk, my understanding from the literature is quite low that you're going to find a functioning follicular carcinoma. But others can comment for sure.
Yeah, Dr. Wu, what do you think?
I would say that that's not a situation I find myself encountering commonly, where we're monitoring a solitary toxic nodule and worried about malignancy. I think many times, probably because I have a surgical practice, I get referred people who want a thyroid lobectomy.
Right.
Emerging technology is radiofrequency ablation for solitary toxic nodules. And for that procedure, we do perform 2 FNAs that should be benign before doing RFA ablation, because after you ablate, it'll look malignant and you'll be confused.
I can maybe reflect on one study that we did. It's a retrospective study we did locally, and we looked at surgical specimen, people undergoing surgery for multinodular non-toxic versus toxic multinodular goiter, and patient with Graves' disease. And although we have to say the study is retrospective and probably maybe geared to a tertiary hospital with a specific population, our really incidence of thyroid cancer within those toxic nodules was in the range of 18 to 20%. And it was as much similar to between patient with Graves, multinodular toxic, and non-toxic nodule. So my point here is could be also population dependent, and as much as, although overall, I think really when we see a toxic hot nodule, one feels reassured that it's less likely to be benign than it's a cold nodule within a patient with a Graves' disease. Dr. Nikita, may I maybe ask you the question? we have actually one of our pathologists has published recently a study on artificial intelligence using cytopathology, like slides from patient going for FNAs. His impression that I got from him that it's a long learning tool, and there is really a long way and needs a lot of work, especially in getting the neural pathway well developed. Do you think it's one of those limitations in cytopathology rather than different from what we see with radiology?
Yeah, I agree. The AI cytopathology in diagnosis of thyroid malignancy, it's not ready for clinical use. And I think the slide that I showed in the presentation is another illustration of that, artificial intelligence is less confident, would call indeterminate test categories more frequently than the human cytopathologist. Ultimately, it gets to the training of AI. I think theoretically, there is nothing that prevents us from training a high-performing AI cytopathologist. It would require probably thousands or tens of thousands of scan slides, which are well annotated by actual human cytopathologists. I don't think that data set is available. Probably an easier task for AI to handle would be determining the adequacy of the FNA specimen, right, rather than actually diagnosing cancer.
Dr. Nikita, how soon do you think we'll be able to see sort of an application that accurately risk stratify nodules? Because you've shown that the data from the one from Samsung, it shows better results than inexperienced radiologists, but they're less than an experienced radiologist. How soon do you think we're going to see applications that are more accurate?
Yeah, that's a very good question. Well, as I showed, there is a number of FDA-approved tools, and most of them, they follow current risk stratification algorithms like TARATS or ED patterns. And because of that, those systems would have the same limitations as radiologists or endocrinologists interpreting the ultrasound. It would likely, those systems would perform at best similar to the best trained radiologist who would interpret those images. The real question is it possible to train an AI which would get outside the limitations of our current clinical systems, which are designed to work, designed to be operated by humans, not by computers, and identify features which are not obvious for the human eye. I don't think there is any solid evidence that computers can do that yet. We might get such an evidence once we have a larger training data set. I would say it probably will take at least a couple of years before we have a good prospective data that would suggest it is safe to use AI to say that this nodule has a low risk of malignancy and it's safe to monitor it versus proceeding with fine needle aspiration.
Yeah, thank you very much. I think because of the sake of time, I think maybe we should get to close the session. If there is no urgent question, maybe there's one coming through now. Is that what? Okay. Okay, I think the question is really what the place of like the new procedures now, like radio frequency and I think maybe Dr. Wu, you would like to answer this question. I think it would not replace really thyroid surgery. There's specific indication for laser and radio frequency. Do you want to comment on this?
Sure. So I think that in terms of non-invasive technologies, they're all along the same spectrum. I think radio frequency ablation is what's standing out right now. The alternatives are cryoablation, as well as ethanol for cystic lesions, and then, of course, using a laser filament. I think the preliminary studies looking at using a laser filament has not worked as well as radiofrequency ablation because the radius of the heat energy doesn't go as far. In terms of, what are the applications of it, I think nobody knows just yet. Who is it best for right now? Probably the strongest indication is for nodules that are benign, that maybe be slightly symptomatic, mostly a cosmetic issue, and the patients are very worried about undergoing surgery. I think there's a growing indication for solitary toxic nodules. I think that there's a push to try to use it for micropapillary thyroid cancers, but I'm very wary of that because, like in my talk, the majority of them don't need to be treated, and this is just doing too much. And then if patients need monitoring or later surgery, it becomes more difficult theoretically.
Thank you very much. Dr. Alauddin, could we close the session?
I'd like first to thank all our speakers. Very interesting talks, and there are areas that were discussed, for the first time. I'd like to thank our attendees. This time we had almost 470 attendees attending with us today. And I'd like to remind them that this session is CME accredited, and within the coming 2 weeks, probably they need to fill a questionnaire before they get their CME certificates. This webinar will be available on demand at the EDS Institute website. Whenever you'd like to go back and check these lectures, it's available. And I'd like to thank our organizers, the MCI group, for organizing this session. And thank you very much, and have a lovely day for those who are in US, and good night for people here in Dubai. Thank you very much.
Thank you very much.
Thank you.
Good day.
شكرا دكتور علي.
شكرا عيني. شكرا.